all of my friends, and let us understand how best we can deal both cancer and COVID together. So, uh, this very question of cancer care still a priority in the existence of a COVID epidemic is that both of them are killers. So these are the competing causes of death, and that's the reason why we always discuss regarding these two issues, because we cannot ignore either of them. Both of them have a high case fatality rate. So if I'm avoiding the cancer patient to come to me, so he will die of cancer. And if I'm not treating COVID, and if I'm preventing them from exposure, they get exposed to COVID and they have a high translation from infection to fatality. So that is why this particular discussion is there today. So, to understand the disease burden, so no number is fixed. Every minute a patient is diagnosed, and a rough estimate is around 7,500 people are diagnosed in India today, and 250 people are dead, unfortunately. So this just suggests that this is not just a simple viral disease. The translation from infection to death is quite significant. So we have seen a lot of flus, common colds, but there the translation is not that high. So here the patient gets into something called acute respiratory distress syndrome rapidly without any clues, and the patient succumbs with not much intervention. Well, moving further. So what is this COVID all about, and do we really know this? So we all have studied in our microbiology days. So we know that coronavirus is not a new virus that we have learned of. So this is something like a simple common flu virus that we know of. But what we have seen is these influenza viruses have something called antigenic shifting and drifting. They keep changing their antigenicity, and when they change it in a significant way, the infection becomes too much where the body cannot handle it. So yes, we know that we have dealt with this virus before, but the problem is the antigenicity is so different than our immunological memory that it takes a lot of time lag wherever immunity mounts an actual antiviral response. It is only the innate immunity that deals in the initial part. The adaptive immunity takes a little longer time. So in the meantime, we'll end up into something called ERDS, and that is the problem with this COVID viruses. So this coronavirus has called common cold in the past. This called something called MERS and SARS. We have heard of SARS and MERS. MERS is basically Middle East respiratory syndrome. It was predominant in the Middle East countries. And again, SARS is severe acute respiratory distress syndrome 1. So this particular COVID, what we call as SARS-2, severe acute respiratory distress syndrome 2. So this is a novel strain that we've seen from 2019, basically from China, where we thought of initially we had animal to people, and then we have human to human transmission, which is there. And the average incubation period is around 5 to 6 days. So however, 14 days is the upper limit of incubation period, which we have, and it is officially named as the SARS-2 coronavirus. So as of now, we don't have the most effective anti-cancer therapy, antiviral therapy. We don't have a third drug that can, like a magic bullet, that can cure this, or we have immunization, or we have any prophylactic therapy as of now, and that's why this disease is a big trouble for all of us. Moving further, so this is what we all know. So from bat or birds, and it has been transmitted to other animal species, and then from them to human beings. So the unfortunate transmission has happened, and after this there has been a significant human to human transmission. This is a matter of concern. So what is the problem with cancer and coronavirus? So if you look into the Chinese data, where if we had 100 coronavirus patients, what we can say is 1% of them had cancer. So from this, what we can understand is that cancer patients are at a significantly higher risk, or they are more susceptible to catch this coronavirus infection. So that is the reason, because they are more immunocompromised, because cancer in itself is an immunosuppressed condition. Upon that, we give chemotherapy, radiotherapy, targeted therapy. All these makes the patient more immunosuppressed, and he becomes more susceptible to catch this infection. And this infection has a high infectivity rate, and the translation to morbidity and mortality is also very high. Leave apart cancer patients, even in patients who are not having cancer, even in these patients, the mortality is so significant. So so cancer is a disease where we have cure, definitely, but it is associated with side effects. The anti-cancer therapy involves major surgeries, morbid surgeries, radiotherapies with significant side effects, chemotherapies with life-threatening toxicities. So in cancer, we always speak of something called the risk to benefit ratio. So because the treatment of cancer in itself has got risks of mortality, we always discuss regarding risk benefit ratio when we treat cancer. So but now now if we have risk on one side, we have benefit on the other side, and now to add to the risk, coronavirus is becoming a big weight on the risk side. And that's why there is a tilting of this risk benefit ratio in anti-cancer therapy, where the risk of treating cancer has increased because of coronavirus in itself. So this tilting is a problem as far as cancer treatment in the coronavirus era is concerned. So moving further, so this is the overall case fatality rate. Case fatality is the infection to the conversion of mortality. So we have diseases like common cold, where the case fatality is less than 0.01%, whereas here, look into the fatality rate. Overall, 3% are going to die of this fatal infection. And if you have no comorbidities at all, you have around 1% mortality. The moment you have comorbidities like heart disease or lung disease, diabetes, hypertension, and it's around 13, 8, 9, so around 10% mortality if you have comorbidities. And cancer also is not an exception, where you have significant, staggering 7% conversion to mortality. So the problem is that an individual, you will not find them only with cancer or only with diabetes. All these are accompaniments. The moment you become elderly, you start getting diabetes, hypertension, heart disease. They all go hand in hand, and cancer is also not an exception to the once the patient ages, cancer also the incidence increases. So basically, this elderly population with multiple comorbidities and having cancer, we can expect a cumulative case fatality of something around 40 to 50%. And that's why we need to have a judicious selection of anti-cancer therapy in this fragile set of population. So this is the vulnerable subgroup in cancer patients. Patients on ongoing chemotherapy, definitely they are at significant risk of catching infections. And if lung is where we are giving radiation, they're at a very significant risk. And if you have hematolymphoid malignancies where the immunity is at stake directly, again there, and the moment age is an issue, definitely age is a big problem. So nearly 3 to 5 times higher need of ventilation by ICU admission is required in cancer patients in compared to those who do not have cancer. So and the next line, if you go into cancer patients on ventilator hardly recover, the whole exercise of saving a cancer patient on ventilator is a futile exercise. So so this gives us an indication of, should we really ventilate a cancer patient? Number one. Number two, should I waste so much of resources when there is a huge disease burden, lack of ventilators in the country? Should I at all ventilate a cancer patient? This is a Chinese data which we have, where only 1 in 32 cancer patients infected with COVID recovered. So the best way to handle COVID in cancer patients is to prevent infections and not to treat it, because the conversion to mortality is very significant, nearly staggering 7 to 10%, especially when they have So cancer patients and ventilator is a question where now we have palliation has been a routine part of uh, uh, cancer care, even in patients who have COVID. So that is one part that we need to understand. And moving further, so cancer patients and so what is the data which we have from China? So there's a prospective cohort study of nearly 2,000 odd patients from 500 hospitals, and the incidence of cancer is around 1%. So the incidence of cancer in the population is not 1%; it's less than 0.5. So definitely, cancer patients are at a higher risk of obtaining COVID infection. So there are three major strategies which were proposed for patients with cancer in COVID 2009 crisis. So what should we do? If there is no emergent requirement of anti-cancer therapy, we should be definitely deferring these, whether it is chemotherapy, whether it is elective surgery. We should be trying to postpone these anti-cancer therapies, and we should be using stronger and more efficient personal protective equipments and intensive surveillance. So whenever possible for a cancer patient, we need to defer. If it is not emergent, we need to defer interventions in these patients. We can ask them after this particular crisis is over. And if at all, if we want a cancer patient to really come to us, we need to advise them a very strong PPE. And then the threshold for testing for COVID in this cancer patient should be very low. We need to test them and we need to treat them accordingly. So what are the aims of COVID and cancer? How do we deal it? So the most important thing is we need to reduce exposure to COVID, and we should not, at the same time, we should not be losing over cancer control. Therefore, we should judiciously select those patients for whom we can defer anti-cancer therapy. So deferring anti-cancer therapy is not a blanket term for all cancer patients. We need to judiciously postpone this particular thing. And more importantly, we have a huge non-cancer population which are coming with COVID infection. We need to preserve both the manpower, infrastructure, ventilators, blood products, everything for these non-cancer patients. So it has multiple implications. Not only you're preventing the infection to the cancer patient, but also you will save the resources for treating the non-cancer patient population. It has large term and huge implications beyond what we think of. So what is Asco, which is the guiding body for oncologists? What does it suggest? So Asco makes few recommendations in a judicious way. So if at all, if the surgery is elective, we need to try it, and there is no urgency, and it is better we can reschedule surgeries unless it is emergent. Then, as far as systemic therapies are concerned, definitely, if you have a blanket term that all chemotherapies, all systemic therapies should be postponed, and let us see after the crisis is over, is not the right way to do. So we need to judiciously select which are the systemic therapies really require emergent action. So we should not defer all the systemic therapies. It is detrimental because it hastens cancer-induced morbidity and mortality, and we will lose that window period where we can effectively palliate them with effective anti-cancer therapy. So cancer patients, if they are in deep remission, or a patient is on maintenance therapy, for example, a multiple myeloma or a lymphoma on rituximab maintenance. So these patients are where we can definitely defer anti-cancer therapy, or we can change it to oral therapies so that we can reduce the clinic visits. So these are the few ways of how we can architect and modify our anti-cancer therapy so that either the infective rate of COVID comes down, plus we can also judiciously treat cancer. And this is what the risk-benefit balance is, what I was speaking about. Well, further on, if at all, if we have a patient of COVID being present in our hospital, should we at all treat? So Asco suggests that it is better we give break of 2 weeks as far as admission in that particular hospital is concerned, or shift the whole patients to a different center, and always try and do home quarantine even in these patients if they are not really sick to admit. Not all COVID patients need admission. There are specific criteria. If there is respiratory rate is more, if there's desaturation, or if there is breathlessness, only these patients require admission. Around 80% of them we can treat on an OPD or on a home quarantine basis with supportive measures. So, and do we have any medicines? We speak of chloroquine. So is it really? We really do not. No, we do not have any proven drug that is really prophylactic for COVID infection. So what are the issues with surgery? So the moment we take surgeries, even the routine surgeries, if we keep taking up, so it consumes operation theaters, it consumes anesthetists, intensivists. More importantly, they will require post-operative care, they require prolonged ventilation and blood products. And again, that's why elective surgery should be deferred because of all these issues. And we should be trying to use alternative schedules. For example, in breast cancer, we have something called neoadjuvant hormonal therapy, or neoadjuvant chemotherapy. So these will give us the window of opportunity where we can prevent the cancer from progression, and we can postpone or defer elective surgeries. Then should at all we should stop chemotherapy or systemic therapy or even radiation therapy? No, not at all. We should judiciously select patient-to-patient basis. We have some protocols and algorithms lower down. So this will help us to understand how to select patients really for emergent anti-cancer therapy, or we can defer. So we should not be differing all patients in a blanket way. We need to consider on a case-to-case basis, risk stratify them, and look into them, and look into the risk-benefit ratio, and accordingly judge about it. So then there has been a lot of literature and thought process regarding should patients in hypertension or renal disease, should AC inhibitors or ARB should be stopped at all? So, well, the whole discussion is because the coronavirus gets into the lungs with these angiotensin converting enzyme 2 receptors, and so when you are trying to inhibit with the AC inhibitors or ARBs, there is hyperexpression of the receptors, and this makes the patient more susceptible to the coronavirus infection. So, but one more observation, what they have done is, even though they have a higher incidence of infection, the severity of infection really reduces. So it increases the incidence, but it fastens the recovery. So therefore, there is no guideline as of now. There is no solid data that we should avoid AC inhibitors. So because if you stop AC inhibitors, the cardiac comorbidities will take up and the cardiac mortality will increase. So as of now, there is no such recommendation that we need to stop or we need to continue AC inhibitors. So if a patient needs it, he's on AC inhibitors or ARBs, we should continue these particular drugs because they are life-saving for cardiovascular system as well. So even though it increases incidence, it fastens the recovery. This is what the data we have. As of now, there is no such guideline whether we should stop this drug to reduce infection. So this is the guidance from ESMO, the European Society. So what it basically says is that in spite of there being a COVID infection, we should not be stopping anti-cancer therapy. We need to have a judicious selection of patients. We should have a continuum of care, and we should get prepared for a new routine, and we need to protect ourselves and our patients, and we need to reinforce support to patients as well. So one more important thing that ESMO has come up with something called teleconsultation. So now we have there are multiple trials. For example, in GBM or in intracranial malignancies, we have something called video follow-up. So just for because the CNS patients basically they are morbid, difficult to walk, to come all the way from home to hospital. In this set of population, we have video follow-up, and it has shown equivalent to OPD follow-up. So with this sort of data, so what we can have is teleconsultation in this particular scenario looks more valid because it prevents clinic visits, it prevents these patients to get exposed to COVID infection. So that is the advantage, and ESMO is promoting teleconsultation in a big way. You can see now seminars and presentations and teleconsultation. So this is another big way to go. So again, telephone, web-based consulting. So this is very important. We always been watching that we need to have a mindful hand washing, and this is the most simple and most effective way of preventing infection. The very important thing what the chief author said was we should also have something called handful mind washing. So we should not be exposed, we ourselves and the patient should not be exposed to these COVID media 24/7 which we have, and this causes more of anxiety, more distress, and this reduces in fact the immunity. So not only mindful hand washing but also handful mind washing is required, and not 24/7 exposure to corona data. So then what are the issues with allotransplant? So there are a lot of patients in line, the BMT list, a lot of patients waiting for transplant. The problem is the donor can get infected. So you give the conditioning regimen and now the donor is infected and he cannot mobilize stem cells. So this issue is there, and the donor may not get beds for admission. There are travel issues. So this is the problem with transplant. So what ESMO recommends is we need to have a cryopreservation before we go on and give conditioning to this set of patients. So what about clinical trials? We have a lot of ongoing clinical trials, especially in oncology, where every other day a new drug is coming. What about clinical trials? So the moment you have clinical trials, you have a lot of infrastructure, a lot of staff required for it. It requires patient isolation. So ESMO suggests either suspend the trial as of now or extend or postpone the trial, because these are not the priority as of now because of infrastructure and strict isolation which is required for these clinical trial patients. So what's the future? So we have a lot of lockdown that has been extended. So what is the future? So if you have an indirect look into China, yes, the epidemic has almost resolved, and we can expect the same with this. The problem is the moment the epidemic is resolved, there is an unmanageable surge in workload after this crisis. So we need to be prepared for this huge bulk of patients who are going to come back after the crisis is over. So yes, we are deferring anti-cancer therapies as of now judiciously, but how do you balance that huge number of patients that are going to come after this particular crisis is over? So this also is a matter of thought, how we can tackle to this huge number of patients post-crisis. So this is the few ways of categorizing in a rough way. There is a scoring from the NHS data where the first priority is for those cancer patients where the cure rate is more than 50%. For example, Hodgkin's lymphoma, there the cure rate is significantly high. And then comes 15 to 50% cure rates like head and neck cancer and chemoradiotherapy. And then coming on to non-curative, like the priority level 6 is something, we have an advanced lung cancer who has a poor performance status. So maybe you can avoid those set of patients with poor performance status and consider only palliative care, whereas a Hodgkin's or a young patient or where the cure rates are significantly high, we need to embark onto therapy. So from all this data, what we can understand is it's all about the balance between the risk and benefit. And COVID is a big pandemic which we had never seen in our lifetime. This is a pandemic that has really spammed the current health system capacity, and there's a high case fatality rate in cancer patients. They get easily infected. Not only they get easily infected, they have a translation to ventilation and ICU, and the moment they are into ventilation, they don't come back. And the whole exercise becomes futile and consumes a lot of resources, and it will not be available to the rest of the population. So judicious positioning of anti-cancer treatment is extremely important, and we have to manage this risk-benefit ratio. So, and COVID is an extra risk for treating cancer right now. So we should avoid unnecessary exhaustion of resources. So if you have a terminal cancer patient with a COVID infection, we should counsel the family that the chances that it's going to return back is extremely remote, and the whole exercise becomes futile, and we should advise against invasive ventilation in this set of patients. And whenever possible, we should be changing to oral medication, subcutaneous, or defer OPD visits. And we should, over and above, after this crisis is over, we should be ready to handle this unmanageable surge in workload. So this is with these sort of thought process and overview, I think I would like to conclude, and I would thank everyone for patient listening, and I would be happy if I can take any questions. Thank you.